assuming that the emergency declarations end May 11th, what it's going to do is already, exacerbate the financial strain, the pressure that hospitals are under now, in a couple of different ways. So right off the bat, and this is estimated by, and I'm glad to send you the article, the Kaiser Family Foundation. They're if you're familiar with Kaiser Health, their foundation does a lot of pretty unbiased as far as that goes, which is hard to find research. They estimate that between 5 and 14 million people are going to lose Medicaid coverage. These 5 to 14 million, which is a significant chunk of Americans, who are not going to have that Medicaid coverage, then are going to be forced to find coverage or not have coverage. So what does that mean for hospitals? On the cost side, patients are sick, they're going to go to the ER, and you cannot refuse somebody life-saving treatment based on their ability to pay. So under the M.H.A. Act. So if you're sick, you're not feeling well, you're going to go to the emergency room. So when folks are sick or they're having a life-threatening illness or injury or emergency, they're going to go to the emergency room. And without the ability to pay, there's a big gap that exists between people who are working and don't have benefits. So it's not like they're completely indigent. I mean, I'm not talking, homeless people. These are people that are working, but they just don't have healthcare benefits. They don't make enough to pay for their own benefits. So that's a pretty big gap, and it's going to get bigger with the ending of the PHE. So, if it's and that's a big swing between 5 and 14 million. We don't know if states are going to step up and kind of fill in the gap. Nobody really has an understanding what that's going to look like. The challenge for hospitals are a couple. One is on the cost side, their cost is going to go up because you're going to have an increase of patients who are going to be, particularly through the emergency room, which is terrible care. It's episodic. There's no continuity. It's not preventive or primary. So what we call in hospitals bad debt, money that you're not really going to collect, is going to increase. On the revenue side for hospitals, again, understanding that Medicare is probably the largest payer by volume for what they see, even though it doesn't necessarily on average cover their costs. When these PHE requirements go away, payments for patients with COVID, you come in with a diagnosis of COVID, even if it's secondary to something else, that was a 20% increase for Medicare. So it was more than likely covering the cost of those COVID patients plus some. Again, this is under the emergency authorization, the money that was there. That's going to go away. Now, some of the public health experts, Tulane is the first school of public health in the United States. Not my expertise, but the concern is if there isn't money in our system is, we're kind of a capitalist country. If there's money, then it'll be covered. There is a public health safety net. We have Medicaid, we have Medicare. The choice of last resort, if you're sick and don't have insurance, is you go to the emergency room, and their only obligation is to make sure that you're stable from any life-threatening injury before you walk out. There's no continuity. They may give you a card to go see a physician, but if you don't have insurance, it's going to be difficult. The concern is that the risk to the society with this money going away is that we'll see over time an increase in COVID patients, which again, it's like this vicious cycle. More patients coming in, not getting paid for their cost of care. Patients who are more susceptible, again, those historically at-risk underserved populations, Black, Hispanic, who are frontline workers. They're not working remotely, working in areas that, aren't necessarily investing in, preventing the spread of the virus. It's going to exacerbate that. So, two sides of the equation. It's basically an income statement question when you're looking at finance. Cost is expected to go up for treating patients that don't have insurance. And the reimbursement that hospitals have been getting since the COVID is going to go away. So those are the two big issues. So what's that going to lead to? We're going to see, I predict that we're going to see continued merger and acquisition. So systems that have a healthier balance sheet will see this as an opportunity for, this is going to sound really crass, but kind of a land grab. Hospitals, in my own market here, the university health system, Fairview M.H.A, has been struggling. They've been losing money before the pandemic. And for them to continue to support their mission, being acquired by a larger, more financially stable partner is really the only option for them. So it's going to put an additional strain on them. So I think if you see additional burnout in the workforce, it's kind of a self-fulfilling prophecy. As you know, the baby boomers, the silver tsunami, there's more volume there eventually, and you have less staff. So you have, 10 staff taking care of a unit. Now you have, and then, one retires and another one just gets burnt out and goes into another industry. Keep in mind that during the pandemic, 20% of the healthcare workforce left. I don't know how many have come back, but they were just burnt out, right? PPE, the stress, you can't, my wife is a clinician and she couldn't work from home. She had to go see patients. So, and then you've got 8, and then you've got 7. So that workload is the same and the stress is still there, but the burden is greater on fewer people. So, that impact on workforce burnout and turnover is going to increase, which adds to the cost, right? If you're a hospital, you can't exist without physicians and nurses. So the same thing that hospitals have been dealing with over the last few years, they have to pay more, right? There's a limited supply of qualified nurses and everybody's competing. So, you're seeing this hospital pays $1 more an hour, and then some nurses go there, and then this one says we'll pay $1.50. Well, it's not, they're not getting reimbursed more for their increased costs. So that'll be interesting to see. I don't think that's